TEDMED and the great challenges. Today, we're not going to talk about organ systems. We're not going to talk about cardiology. We're not going to talk about isolated elements of clinical care. But today, we want to take a look at the patient and a more comprehensive look at whole patient care. It promises to be an interesting discussion, and thanks again for joining. My name is John Nosta, and I'll be moderating today's session. This session is part of the Great Challenges series at TEDMED and sponsored by the Robert Wood Johnson Foundation. Our goal, the goal of the Great Challenges program, is to address 20 of the most pressing issues in medicine and clinical practice today. Our goal is not to solve these problems, but to establish a dialogue and talk with experts on our panel today, but also look to the broader members of the TED community to have them engage in questions and comments. To that end, we'll be taking questions from viewers on Google Hangout, on Facebook, and on Twitter. That's Twitter at TEDMED, and please use the hashtag #GreatChallenges with an S at the end, and we will certainly try to get to as many of those questions as we can. We already have some coming in, as I see. My name again is John Nosta, and I'm Executive Vice President, Senior Strategist at Ogilvy Common Health. I'd like to welcome our panel today and introduce them quickly before we move into our program. Dr. Jack Der-Sarkissian is a board-certified family practice physician at Kaiser Permanente in Los Angeles, a firm believer in the philosophy of total health. I'm looking forward to having him bring his perspective, and welcome. Diane Meyer is director of the Center of Advanced Palliative Care, a national organization devoted to increasing the number and quality of palliative care programs in the United States. Blair Sadler is a senior fellow at the Institute for Healthcare Improvement and a member of the faculty of the UCSD School of Medicine. Doug Thomas serves as the ACO Director for the developing and implementing a strategic business plan for the Cambridge Health Alliance and transforming CHA transforming into an ACO. Susan Hernandez is a fourth-year PhD student and research assistant in health services at the University of Washington. Her research interests include organizational approaches to improving quality of primary care medicine. So welcome everyone to our panel today. And let's start with a very, very simple question that might have a complex answer. What really is holistic care when we talk about holistic? Maybe we can frame that discussion up a little bit. And Jack, off to you for our first answer.
I think holistic care is a very complex condition. And I think the best way that I can probably describe it is to describe my own experiences with the healthcare system. And one story I'll relay is when my father became very ill, it became very evident to me that the healthcare system that he was engaged in was very highly dependent on him to engage the healthcare system. His physicians were not talking to each other, primary care to specialists. The pharmacy was not integrated with his physician's care, therefore they didn't know, or he didn't know whether prescriptions were getting filled or whether they were not. Nobody was outreaching to him. The care gaps that he had in his life were not being addressed, and then at the end of life, much of what had to be done for him was highly dependent on me and not the healthcare system to take care of. So as a family doc, I really treasure the fact that the full healthcare team work together as a true team, that I am supported by my specialists, that the pharmacy is also addressing my patient's needs, or letting me know when medications should or should not be taken, whether a patient has care gaps that need to be closed. I think we have very episodic care, and from my own personal experiences, as my father was going to the end of his life, it was very frustrating, and I think it could be improved.
So let me comment on two particular areas there, Jack, and this is to you. It sounds as if you're speaking a little bit about integrated care, and I want to tease out the difference between holistic care that may go into a broader aspects of the patient dynamic. So Could you tease that apart for me? Integrated care is a multi-special approach, specialist approach to the patient, versus maybe the other kind of broader type of holistic care, if you will.
I know within my practice as a family doctor, most of my patients want me to treat them as a whole patient. They want me to understand where they're coming from. They want me to understand the challenges that they're having in their lives, and then where they are as far as getting to the goals in their lives that they want to get to. And for me, holistic care means integrating that whole approach. Now, honestly, as a primary care doctor, I can't do it all by myself. I have to rely on my team. I have to rely on my nurses, my pharmacists, the specialists, and my patients at the end of the day want to be assured that everyone is addressing their whole care. That, to me, defines my version of what holistic care means.
Interesting. Diane, let's take a look at that. I mean, particularly with end-of-life care, and perhaps touching on this concept of mind, body, spirit, and expanding the sort of the definition of holistic much more comprehensively. Then we're going to bring it back to medical school in a minute. So we'll revel in the science shortly.
Okay. Well, I think what Jack was talking about was whole system care, that the system should work in a seamless, coordinated way with the patient's needs and concerns at the center. I want to shift the focus a little bit to the person, away from the healthcare system. And in my experience in palliative care, I take care of a lot of people with chronic diseases who are going to live for a long time with whatever that disease is, whether it's heart failure, emphysema, or stroke. But the healthcare system doesn't pay attention to the critical elements of that person's personality, family, community that are critical to them getting appropriate care. So, for example, if I give a patient a follow-up appointment 2 weeks after discharge from the hospital, but I don't pay attention to whether or not they have transportation, can afford transportation, or have someone who can help them get there, that was a waste of everybody's time. Similarly, if I give people prescriptions to be filled, but there's no pharmacy in their neighborhood that carries, for example, opioid analgesics for pain, again, I'm not addressing the whole person in the context of their family, their socioeconomic status, their community, the things that really do determine not only their access to care, but the quality of care that they receive.
Mm-hmm. Interesting. So it really is a complex scenario in terms of managing these patients. And often I would bet that some of the fundamental issues of whether or not your pharmacy has an opioid analgesic is something that is outside the purview of clinical care. And that's very interesting to me, and I think that's an important element that we could discuss a little bit further. But let's take a step back, and perhaps, Jack, you can answer this, because I want to talk about medical school. And perhaps it's graduate school or it's a master's program, whatever it may be. But how is the practice of medicine taught? Is it a systems-based phenomenon? Are we teaching organ systems? Or are we teaching holistic care in any way, shape, or form in the context of, let's say, medical school?
I think medical school education has dramatically changed over the many years. I do know that we have integrated more of a patient approach, essentially training everybody to have more of a primary care approach no matter which specialty that they're going to go into. And I think that's probably been more of the positive. We do need to learn the science. That is critical. We do need to learn the evidence because in the end, we're content experts for medicine. But at the same time, we need to learn that we are taking care of people and they have complexities in a variety of resources, whether it's their family, their social networking, their work environment. Those things do need to be taught. I believe in the end, I don't expect everyone to be a primary care doctor, but they probably do need to have the concept of primary care at the heart of what they do. An orthopod who may do a knee replacement, they need to do what they do really well, but they need to work very closely with the system, including the primary care doctor, the pharmacist, so that they all have to be integrated to ensure that the patient gets the proper care. And so that training needs to be an integral part of medical education. Is that occurring everywhere? I believe it's occurring probably more now than it had been maybe 20 years ago. And I believe medical schools are very attuned to making this happen in the future.
Is there an emergence of more primary care physicians driving practice dynamics, or are specialists becoming more primary care minded?
We do not have enough primary care doctors to fill our needs, and I don't anticipate that changing, and there's a variety of reasons which we can get into. I think at the end of the day, the specialists out there know that to ensure success for their patients, they need to be primary care minded. A cardiologist taking care of a heart problem can't ignore the rest of the body. I think we just heard a patient who needs an opioid prescription going to a pharmacy that doesn't carry one, or that their family doesn't have a way to transport. That affects the entire spectrum of medicine. So I think everybody within the field, be it physicians, be it all the practitioners, have to be very highly attuned to their patients' needs. So no, we don't have enough primary care doctors. I don't know if we will have them in the next decade or so, but I think the specialists are being driven, and probably will be more so in the coming years given the changes that are going on in the healthcare system to promote that.
I'm curious, when we talk about medical specialties, that we have cardiologists and endocrinologists, and we have primary care physicians, does anyone know of a physician or a practice group that practices holistic care as part of the nomenclature? Or is that, oftentimes I see that tends to be, not quite science-based and a little bit associated with yoga or nutrition, and I wonder if there's something out there like that. And does that hurt or help the concept of primary care as a medical discipline?
John, I could
chime
in on this.
Mm-hmm.
So in terms of putting together an accountable care organization, I think this is one of the underpinnings of what this migration is all about, is not just seeing primary care specialties as the epicenter, but really understanding how our entire community comes together to support the population. And certainly, I work within a healthcare system, and primary care providers and specialists are critical. But for the most complex patients in particular, that aging services agency or the detox facility or the neighbor in the community that actually knows about who's home and who's not, some of those types of resources are actually the most critical to ensuring that people are achieving broader health. So this is an element in which Cambridge Health Alliance has played some role in putting together an integrated clerkship where for many years now, and we're expanding it, primary care providers and specialists alike spend some very concentrated time in primary care following patients, making sure that they understand the full continuum of patients' needs. But a real challenge for us, and I think most health systems for sure, is to really think way beyond our borders and understand and really engage with our communities, because there are very sophisticated lay personnel that in many cases are central to achieving good health.
Susan, I want to go over to you because I want to discuss some of these borders and some of these things that transcend clinical medicine, and talk about your work in looking at organizational approaches to a more holistic approach.
Yeah, and I actually think that some of the things that I've learned about in my research have really to do with training future physicians and training them in a whole different way to practice medicine, where they're really including the patient as the focus, and the patient is really directing how they, set up a clinical plan for a patient. And then beyond that, also being able to coordinate care across the different systems. And so, oftentimes as patients age, their healthcare becomes more complex, and that requires a lot more clinical hands that touch the patient. And to make sure that things don't get dropped along the way, there needs to be a coordinated system. And you know, in my research, I've heard a lot of clinicians talk about how it's really difficult once they start to collaborate with clinicians that are outside their system. And you know, we hear about the Kaisers and we hear about some of the other really great integrated clinics, but most of clinical care is not delivered in those integrated clinics. And I think right now what we really need to do is find a way to break down the silos between kind of the independent practices.
Mm-hmm. Let's go back to some of the obstacles to care, especially in the area of your work, Susan. What were some of the surprises? What were the barriers to care in general, and perhaps even holistic care? Were they economic, sociologic, you know, looking broader than just a myopic clinical perspective?
Right, and I think it's not a surprise. You know, when you talk about holistic care, it's really about thinking about the patient within their social context, and that really did not come up in any of the conversations that that I've had with clinicians and healthcare executives about how to restructure care and make it more patient-centric. And I think that's because we really don't know how to do it. You know, this is really, you know, it seems kind of, you know, funny that we're now thinking about how to include patients in a clinical plan, but it's actually the truth. And so there's, I think, not a lot of experience with being able to include patients in a way that, you know, clinicians and everyone, the team really feels like they're a part of it. And so I think some of the work that's being done right now, like shared decision making and, you know, teaching patients and teaching the population to be, you know, very proactive in their health, I think that's kind of where we need to start, because I think both clinicians and patients don't really know what their role is. And so part of what we're doing right now is defining that.
That's an interesting point. Do clinicians, do patients pass the buck a bit and say, that's not my job, that's my doctor's job, or the doctor says, that's not my job, that's the patient's job? And is that a problem that exists currently in your experience?
You know, anecdotally, I think that that's true, but I also think that from a patient's perspective, you know, even the most educated patient, even, you know, I had some experience kind of taking a lead in my grandmother's healthcare, and, you know, even with all my experience, it's still sometimes hard to question physicians when you're kind of in a place where you don't know too much, and being able to ask the right questions, that's something that you develop and you need to be taught. And so, you know, for instance, how many of these procedures have you done? You know, some of the basic questions, patients don't know that. And so there's an education that needs to be had for patients. And there's not really a good way to deliver that, I think, right now.
So we have an interesting question from George Margelis on Google+, and he asks, can whole patient care actually be taught? Or does it come out of more of an empathetic human characteristic that's learned? And I'm curious, is there a methodology to teach holistic care?
There is, and this is Jack. There is a methodology. This is something that can be taught all the way from not only medical school, where expectations and accountabilities are set up, but also through residency and through fellowship programs. And the team concept has to be integrated within medical education. Medical education in the past had us all becoming essentially cowboys, that we could all function independently from one another. That paradigm has shifted, And I think for us to be successful in this very complex environment, and I think a lot of the questions that you were asking, what you were hearing about patients somewhat disconnected from the process, I don't think patients are disconnected because they don't know, but they don't know what they don't know sometimes. And we have to anticipate things occur regularly. And so this can be taught, and it can be done very successfully, but it has to be done early, and it has to be done as an accountability through the whole spectrum of medical education.
On one of our prior Great Challenge discussions, we talked about 95 cents out of every dollar being spent on disease-related care, and that 5%, 5 cents out of every dollar is preventative care. I'd like the group's comment on that as sort of a practical reality of dollars driving care, but also, is it human nature? Do we wait for a problem to occur and then we fix it? So being holistic in the general sense of the word is counterintuitive in some way? Jack, you're up. You can take it, and we'll move around the panel on that.
Sure. I mean, the way the payment system has been structured here in the United States is that we get paid to do things rather than to affect. So for me to keep my patients healthy and to keep them out of a hospital setting and to ensure that they don't get sick is not enumerated as well as, say, doing procedures for them. And so that has somewhat driven the procedure-oriented care that a lot of patients have gotten. It's interesting that you mentioned that 5% has been spent on prevention. There are estimates that 70% of our budget is directed toward addressing behaviors that we do, whether we overeat, we smoke, we drink, lack of exercise, stress. Those are the kind of things that lead to a lot of the disease burden that we do. And in the end, we take care of diseases because of those behaviors. So it is very lopsided. And I think the payment system has been structured over the last 40 years to promote more of those kind of approaches.
Anyone else on the panel talking about just the nature of the skewed type of care that we receive?
This is Diane Meyer. I think the other thing that's interesting is the imbalance of spending between medical care and social supports. In other developed countries that spend less than half than what we do per person on health care and have much better quality outcomes than we do despite our high spending, the ratio of dollars that go to social support. So for example, sending a companion into the home to help an older person bathe, or to help an older person get groceries into the house, or what in England they call tuck-in and wake-up services. Someone comes to help someone get out of bed and then back again to help them go to sleep. Those other countries spend a lot of money supporting the chronically ill at home in their communities. The United States spends almost nothing on that. And because we don't attend to those social contributors to vulnerability, people go to the only place that they can, which is to dial 911 and go to the emergency room. So the system actually is perfectly designed to get these results, and we need to redesign the system if we want to see different results.
Diane, I want to follow up on a question. We're getting a lot of traffic, a lot of questions on holistic patient care in the context of end-of-life planning. Mm-hmm. I'm curious, is that a model of success? And are there learnings there?
I want to challenge you on the use of the term end-of-life. Most of the patients we take care of have serious illness. Mm-hmm. They may have functional impairment. They may be somewhat cognitively impaired. They may need another human being to help them through the day, but they are not dying. Mm-hmm. They are not near the end of life. They may have many years to live with a serious illness. And the approach to palliative care is holistic because what it does is start with who is this human being that is our patient and who is the family around them and what really matters most to them. What are their goals? What are the things they want to be sure to accomplish, and what are the worries that keep them awake at night? And when we start there with determining what the goals for medical care are, rather than, time to get another PET scan to see whether the fifth-line chemotherapy is helping or not, if we start with the patient instead of with the disease, the care becomes much more holistic and person-centered. And surprise, randomized controlled trials say that people who get palliative care actually live longer than people who do not.
I'm going to repeat something that you just said because it really rang true with me. And that is, ask yourself, who is this person? And the humanization of that intellectual construct versus what is the differential diagnosis or that hard science is so important. I want the next section of our discussion today to talk a little bit about observed medical advantages in the context of holistic care. And Diane, you had touched upon that you actually do get some real tangible advantages. But let's go to you first, then I'm going to challenge the group. Are there outcomes data? Are there levers, carrots that we can help communicate to practitioners to help drive the success of patient care? So Diane, first with you.
Well, again, no matter what setting you look at it in, palliative care delivered through hospice, delivered in outpatient cancer clinics, delivered by telemedicine to people in rural communities, the trials show that because the care is person-centered and asking, how are you sleeping? When was your last bowel movement? Have you refilled your prescriptions? What are your biggest concerns? The result is that crises are prevented and patients don't end up in the ER or the hospital. And what's interesting is that the goal of this kind of care is not to save money. The goal is to provide the highest quality care to these vulnerable patients. But as an epiphenomenon of better care, you don't have a crisis, you don't have to go to the ED, you don't have to go to the hospital, so the cost savings are enormous. But I think what it's difficult for people to register is that less acute care, less hospitalization, less emergency room use actually not only improves your quality of life, it improves your length of life. You live longer if you avoid hospitals.
Doug, I want to ask you if there are strategies in place to help achieve this, and then we'll go back maybe from a more pure clinical perspective over to Jack and then follow up with Blair. All right, Jack, maybe Jack can jump in. Are there home runs? Are there any aspects?
I was on mute, yeah.
Okay, well, let's take it to Jack, and then we'll go over to Blair. I want to look at some strategic perspectives on how we can codify this. So Doug, you're up. Are there some strategies there that we can put in place or exist now?
Yeah, sure. Sorry about that. Yeah, I think I just want to tag on to what both Jack and Diane have said. I mean, I think the movement to new payment models is really critical because the fee-for-service system really does kind of send us all off into our silos, and thinking about more kind of global ways that we pay for whole patient care is really fundamental. And then I think the palliative care, certainly the literature shows clearly the benefits of that. And I know in a population, even really complex populations that we work with, introducing kind of care coordination resources, nurses, social workers, community health workers, we've seen dramatic improvements in populations that were already, quote, managed. And we've seen, dramatic reductions in emergency room visits and inpatient stays. And most importantly, patients living longer, healthier, happier lives, and certainly major reductions in costs. So, people talk about all the waste there is in healthcare, and I think it's true, and it's really at the we're sacrificing our own health while we're actually expending much more than we need
to. Who's Jack, I think, or Blair?
Yeah. I can comment on both what Doug and Diane said. I wholeheartedly agree. I think if you came to see me as a patient, I would try to see where are your goals of life, where do you want to go, And then I would do an inventory of behaviors of what you're doing. And I think it's been very clear from the evidence, if I advise you on smoking, on excessive drinking, of overweight conditions or obesity, I can prevent diabetes, I can prevent hypertension, I can prevent hyperlipidemia. These things over a spectrum of a decade or 20 years or more could have a huge impact in your life. And so I think interventions of behavioral change are very critical. And I think the clinical evidence is very much there that those kind of interventions are not done enough, and they're somewhat more late in life rather than early in life, along the process of the disease process.
We tweeted Dean Ornish, Dr. Ornish, to see if we can get him to chime in here. But many of us know about his interesting work going back many, many years about coronary artery prevention, even regression, and a holistic approach. It makes a lot of sense to me. I think it was a compelling argument, but most people don't know about it. What's the disconnect there behind compelling angiographic-based reduction in atherosclerosis versus taking your statin and hoping for the best?
I just like to say something. You know, as a lifetime learner, I always think about, well, what's the next step and where can we find more information? And, you know, PCORI was set up just for that, to really put the patient's needs and preferences in place. And PCORI has only been around a few years, and for those of you who don't know what it stands for, it's the Patient-Centered Outcomes Research Institute. And I think that's a really exciting institute, and the research that comes out. I'm looking forward to the research that comes out from there. You know, and it really, I think, tries to quantify in some way or integrate the patient's perspective in clinical interventions. And I think that's where it's most used. But I think it has applications in you know, beyond just pharmaceuticals.
Susan, I want to go ahead, Blair, please.
If I could just jump in for a minute. First of all, apologies for some technical things. I've been kind of off for 20 minutes. If you don't mind, I'd just like to shift the gears completely to a different direction, not as a clinician, as a former hospital CEO for 26 years, and kind of looking at the barriers to access to primary care and giving the frontline clinicians, whoever they are, enough time to treat the whole patient, rather than always being in a rush. You know, 18 minutes, 18 minutes, 18 minutes, and often being pushed to refer to a specialist unnecessarily and all of that. And I think, as one of the 10 questions that have come in advance, one of the things I hope we spend a little bit of time on is the use of nurse practitioners and physician assistants and other health team members and behavioralists, in addition to the primary care physician, is hugely important. It's working well. Health Affairs, the new issue that was out yesterday, has very powerful analysis that you could literally eliminate the primary care physician shortage if you use the better array of healthcare teams. And, you know, it takes 2/7 as long to train a top nurse practitioner or PA as a physician. We've thrown huge amounts of effort from foundations in the federal government against trying to change the ratio of primary care physicians and specialists, and we're not really, frankly, getting very far with that because of the reimbursement differentials and reward systems. So I just hope that in our agenda for the next 5 years under the Affordable Health Care Act, and really these 30 million more Americans that are going to get insurance, that's the good news. The bad news in Massachusetts shows us that is they're going to still have huge access problems, and if we put it only on the back of the doctors, we're not going to get there.
Blair, I want to jump in because we're getting some comments on that very question. And Jolene Miller writes in on Facebook about the expanded role of a variety of healthcare practitioners, moving not away from the physician, but the inclusion of the physician, but also nurses, PAs, pharmacists, and a variety of allied healthcare practitioners. And in your experience in the hospital environment, could you speak more to that trend and how that's going to shift the burden of care to a variety of stakeholders? And then Jack, to you from a clinical perspective too.
Yeah, I give it sort of that, absolutely that's the trend, and I'd sort of say it from two perspectives. One is one of the founders of the Yale Physician Assistant Program 42 years ago, which is the fourth in the country at the time, and sort of having a long sort of history with how those work. But also then as a hospital CEO, and it's been amazing if you look at the 100,000 PAs and the nurse practitioners out there, they are working effectively in hospital settings and specialty settings, but a lot of them in primary care and in hard-to-reach areas. And with the new technologies that can allow communication more and more effectively between patients and providers, whoever they are, and the physician supervision issue, I think the future is almost unlimited to do this well.
Mm-hmm.
I'd put real emphasis on it.
I think that the technological innovations in this area are very important and would help expand care. We're going to leave that a little bit later in the discussion because I think that's a very interesting opportunity. But Jack, perhaps from a clinical perspective, are you transferring care? Are you transferring responsibility to a broader array of healthcare practitioners? And what's your experience with that in real life?
In real life, I don't think I could survive if I did not depend on my extended team to help me. I have care managers who help me monitor my patients who have chronic conditions, who are outreaching to patients and not waiting for patients to engage the system, not waiting for them to get ill. I have my nurses. I work with a nurse practitioner and we have a good service agreement between us about roles, responsibilities, communication. I work extremely well with my pharmacy group. I expect them to help me, to assist me with my patients, to check for interactions, to warn me if patients are not refilling medicines or have been put on inappropriate medicines by other physicians. I can't do all this by myself. I need an integrated team to help me. And I think without this integrated team, I don't think primary care or the whole patient concept will survive. And so I completely agree with Blair. I think we need to think outside the box. And as long as the patients know that we are all communicating, that we are all in agreement with the goal of care for that patient, and it doesn't have to be the same for every patient, but that we're all on the same page, I think that is what patients want and that's what patients expect.
So I like to hear the fact that we have a hospital administrator and a clinician agreeing on this point. In the reality of clinical practice,
miracles do occur.
Well, and again, and there's my question to the group: is it a miracle, or is it really emerging as a common trend that we're seeing the integrated practice of medicine, including the management of medicine? We know when we talked about the components of care, the nurse, the physician, the nutritionist, it was the hospital administrator that wasn't included in that group. And how important is that in the reality of medicine today?
If I could just jump in quickly, I think the huge seismic shift to the triple aim, from the single aim of patient care, but now to the second aim of population health, and the third aim of lower cost per capita, which is what CMS is driving and the accountable care organizations are being formed to do. That is, I think you're going to see executive non-clinical leadership, people like from my background, embracing this enthusiastically because they are getting a lot of negative feedback, bad satisfaction scores with delays and waiting times, and physicians who are working impossible hours and still patients who aren't getting there. So I think you're going to see, from the administrative standpoint, great enthusiasm for the team concept, and hospitals will be investing in either themselves or federally qualified health centers, or in the ambulatory space will be enthusiastically doing everything you just heard described.
So Susan, let's go over to you, and I hope I don't. I hope this is a question up your alley, but in terms of the protocols, the things you're looking at, you talked about outcomes data that will be coming in the future. Is this on your radar, the integration of the financial and the logistical aspects of holistic care?
You know, I think the research that I've done so far is really about coordination and integration and less about holistic care. I think Diane has been really great about distinguishing the differences between the two. And so, so I can speak to that. I think in terms of holistic care, I think there are organizations right now that are starting to attempt to figure out like what kind of models work for them. And I think you know, sometimes it's called patient-centered care and not holistic care, and I think it gets at the same concept, and that's really putting the patient at the center of, you know, a health plan and thinking about them in their social context. Currently, I'm working at the VA and doing some research around their version of the patient-centered medical home, which is called patient care aligned teams. And you know, I think it's the VA is a very unique system in that you know, they don't have that payment component that they have to worry about. A lot of the other organizations, you know, in order really to make any progress, you really do need that payer perspective. And so I think Blair talked about, you know, how the clinical perspective was missing from that. Well, the payer perspective is also missing from that. And really, to make any change, you need all those different components, because if you know, clinicians are continued to be paid the same way, there's no financial incentive or support for them to make changes. And you know, a lot of the changes and practices that need to be made require redistribution of resources. And so if your payment systems are not aligned to support that, it really becomes difficult to, you know, change.
Susan, you touched on I think maybe the third rail of this, and that's the controversy that exists, or the issue of payer versus provider, and who has the D, who has the decision. And Doug, perhaps you can address this from a broad perspective. You know, are they mutually opposed? While administrators speak to quality care, and physicians certainly speak to quality of care, do they have different endpoints? Are they contradictory, or are they inclusive?
Well, they can be contradictory, but they certainly can be completely complementary as well. I mean, I think here in Massachusetts, where this transition in payment systems is happening at a very rapid clip. I mean, many systems here have 50, 60, 70% of their patients being paid not under fee-for-service, on a different way. And all of the systems here, it's just the norm now for us to be thinking completely differently about how we structure our care teams. And, you know, whether or not even not only what we're talking about here in terms of nurse practitioners and PAs and nutritionists and pharmacists and all being part of the team and being very much more equal members of the team, and everyone trying to work to the top of their license, but also really pulling in our community partners who really know people the 95% of the time, the 99% of the time that they're not in the healthcare system. And they know these folks much better than we do. So I think there is a complete mind shift going on, especially there are probably certain parts of California, certainly Kaiser's been about this for a long time, where the idea of how you work with a patient to support their goals, embedding, you know, patient-centered care plans and our electronic medical record, these things are all changing very rapidly, and we're partnering the same way with the health plans, who are transferring some financial risk to the delivery systems, and we're all starting to try to kind of optimize our different expertises, because health plans still, and for as far as I can see, will have a critical role, but health delivery systems are definitely taking on a much broader role in alignment with where payers have been in the past, and hopefully where patients need us to be.
You said the transference of risk, and I think that's an interesting concept, that payers are willing to transfer a little bit of that risk. Where do we stand now in healthcare from a perspective of the United States, but also globally, and I challenge the group also, are there models of care or holistic care that we can learn from outside of the United States?
I would just offer Canada as one example. I mean, there's so many good ones to look at, but to build on the Massachusetts comments, if you have a global budget, then that's the payer contract you have with the provider system, which is the clinicians and the administration. You have a fixed sum game, and that risk has shifted to you. And you're responsible clinically and financially for the health and well-being of picking up 600,000 patients, in Vancouver or whatever. That's where we're going, and I think that's what the Massachusetts experience is showing us. And other countries have tried that. It doesn't have to be a government-run system. As the Massachusetts is showing, we think the Blue Cross and Blue Shield of Massachusetts is the payer, but they're changing fundamentally the rules of the game.
So that leads us to the compensation model of care. I want to talk a little bit about that. Adam Watson on Facebook wrote that question. And fundamentally, do we have to change the compensation model? Are there models to look at? Is this something that is emerging now? Blair, just from an administrator perspective, your thoughts?
I think we do, and I think we are. Massachusetts and Kaiser and others have been leading the way in this, but moving from paying for volume to paying for value is what it's all about, and that's the centerpiece of the Affordable Care Act and CMS and what they're doing. And so whether some of it's driven federally to state or whether they're trying state models the way Massachusetts has done, I think the payment model has to shift and is shifting, and once it shifts in a fundamental way where 60 to 70% of contracts are in a completely different risk model, you're going to see behavior change and team care really come of age.
So Blair, I'm going to echo that comment because I think that was a very interesting point, that clinical medicine needs to move from volume to value.
Yes.
And it sounds like it makes sense. It's a good soundbite. Jack, can you move from volume to value?
I don't know how to define value, but I do know how to define effect. And I think maybe that speaks to the concept of value. And I think we don't necessarily get compensated for effect. If I keep someone from getting diabetes, I don't know if I would get paid the same as if I took care of him when he became a diabetic and got him on triple medications and get them on dialysis and so forth. So the payment structure should, in my opinion, should be value. That is true, but in essence, what I'm saying is effect. I want to keep patients healthy. I want to be compensated for doing what the end result is, not necessarily widget counting is what I would like to get away from.
So Jack, when you talk about a particular clinical event, you can get paid for an exam, you can get paid for an EKG. When you look at things with a broader timeline, such as wellness or the prevention of a particular clinical outcome or endpoint, how do you measure that, and how do you quantify that in the context of reimbursement and value? That's something that confuses me.
Yeah, if I had ownership of that patient, and I think Diana had spoken to this before about understanding where the patient's coming from and where they are in their community and where they are into their services. But if I get measured on the quality of how I take care of that patient over time, if I provide the proper service to that patient, if I'm keeping that patient happy, if I'm providing proper access to that patient, those are the things that I should be graded on. If I keep them healthy, if I keep them happy, and if I could see them or have them see me whenever I can, and that would be over a spectrum of time. So how do you pay for that on a single episodic visit? That would be very difficult, but that's exactly the system that we have. And so there is a major incentive right now for people to do these long-term interventions when you don't get compensated for those in an episodic visit.
So Jack, if you do a bad job, do you get paid less?
Within the system that I work in, yes, I would.
Mm-hmm. Interesting. Diane, Diane, from your perspective, in the context of the care that you see in palliative care, how does reimbursement and costs play into your care structure? A little bit.
Palliative care is like any other medical specialty, like cardiology or endocrinology. Doctors and nurse practitioners get paid through regular insurance, through Medicare, fee-for-service, for our time spent with the patient and family. Other members of the team, like social workers, chaplains, and others, massage therapists, yoga therapists, we have a big team, do not get paid for their services. So most palliative care teams are supported by a diversified portfolio. Some is fee-for-service billing, some is institutional or health system support. A lot of us bring in philanthropy to support things like massage therapy and yoga therapy and art therapy for our patients. But as the system is moving, as everyone's been discussing, away from fee-for-service and towards taking care of a population of patients under a budget, one of the highest priorities in that system will be the delivery of palliative care to the seriously ill, because not only are they the population most vulnerable to terrible quality in the old system, but also they are the ones most likely to drive spending. So if you want to control that, you've got to have the right model of care for the right patient population in the right time and place. So I think the future of palliative care is very bright because of healthcare reform.
Interesting. We have about a little less than 10 minutes. The time goes very quickly in these conversations. But there are two areas that I want to touch on. And in terms of just looking at the patient driving care versus the HCP driving care, who becomes the advocate for holistic care? That's number one. And then I want to finish up with a look to the future, particularly about the integration of new and emerging technology and how that may in fact help manage some of these conditions. So, Diane, when you think about holistic care, who is the primary advocate of this concept?
Well,
Patient,
it depends.
physician. Mm-hmm.
It depends on where the patient is getting their care and from whom. Mm-hmm. In my hospital, which is a typical quaternary care referral, highly fragmented, subspecialized system, the palliative care team often serves as the patient's quarterback, as the kind of added layer of support that does the communicating with the 6 or 7 subspecialists, with the daughter from California. I'm sure if I was in California, I'd be saying the daughter from New York, but I'm in New York. So
right.
We play that role of clearinghouse, synthesizer, and cross-communicator for very complex, seriously ill patients and their exhausted families. Ideally, that role would actually be played by the patient's primary care provider, whether that's a nurse practitioner or a family physician or an internist. In many parts of the country, that is who does that. But because of the rise of hospital medicine, sicker patients in the hospital often are not seen by their primary care doctor. Their care starts to devolve to the hospitalist in the hospital and the specialists who control the heart failure or the oncology care. And the result is the loss of that quarterback function, loss of that intermediary added layer of support and communication function. And that's where palliative care teams often step up to fill in that breach.
So Jack, let's flip that dynamic on its head, and let's take the patient out of the hospital setting and look at the 50-year-old obese diabetic patient who's home, who's generally well, but is teetering on this precipice of bad outcomes. And we want holistic care to be an important part of this man's lifestyle. At what point does the patient have to take control, or is it the healthcare provider who's going to drive that dynamic? I know it's not one or the other, but I'd like your comments on that.
It really is not one or the other. And I would have to stress that every patient has their own drivers. And what I do for every patient that I see is I try to see where are they today, what are their aspirations, what are their goals, and do they understand the implications of the conditions that they have. I think behavioral change and aspiring to get to certain goals is a long-term relationship. And while I see myself as more of a coach and more as a guidance, and I think every patient is very different. I think the patient is the ultimate driver of what they want. If a patient doesn't want something and I want it, it will not happen if that is not something in the aspirational goal for the patient. But what I can do is I can put that image in front of them. I can tell them what the consequences are, and then let them make the best decision for themselves. And so again, I think it's a good relationship.
To pull out another quote that I think is very resonant, the patient is the ultimate driver of care. And that's an important dynamic that I think helps us sort of frame up this context that physicians have to empower their patients, or patients have to feel empowered. We've just got a little bit of time left. Blair, I think that you wanted to... that was it, Blair? Oh, no, I'm sorry. Yeah, Blair, you wanted to comment quickly.
Well, just my crystal ball with all of us. I think Maureen Bisignano, the president of IHI, loves to say, we're moving from what's the matter with you to what matters to you. Very different question. Secondly, I think that means continuous conversations between healthcare team members and patients. And third, with the low-cost technology and the social media that's possible, with the things that are on iPhones today, and a patient can be communicating 24/7 to a member of the healthcare team and get a response back in a timely way, or going the other way, a quick reminder about compliance, as the physician colleagues can tell you, just a reminder to take something very basic. Those cost nickels and dimes, and that's what matters to patients.
So Blair, two important points, and I'm going to tee up a future program. On the 14th, we will be discussing the nature of communication and the dialogue between all the stakeholders, from caregivers to family members to patients, and it's the very nature of that dialogue and appropriately motivating patients. So we're going to have something on the 14th that's going to be very interesting, so please mark your calendar for that event. Finally, as we wrap this up, I want to look to tomorrow. Let's look to the future, and perhaps we can touch on the role of technology, the role of emerging data. I know that that we talked a little bit about some of the trials. Susan, some of your work. So let's go just around the group as we wrap this up. What is the promise of technology, and how does the future look to you in terms of managing the patient from a more holistic perspective?
I think it's not the silver bullet. You know, in talking to a lot of provider organizations, there are tons of technological challenges in using data that we currently have, and I think as we go forth, you know, I hope that we're able to overcome those challenges and be able to pull out clinical information easily and be able to link that to payment systems in a way that makes sense. And so I think there's a lot of work there left, and it's not the silver bullet. I think it's definitely a component, though.
That's fair. Doug, you've been crafting your strategies to help break down these silos. Is it working, and what's the future look to you?
Yeah, I mean, I think it is working. We have a huge way to go, but you know, having electronic medical record systems that at least connect everyone with inside a healthcare delivery system is a start. But there are enormous opportunities for home-based monitoring, et cetera, that I think, as we think to the smartphone of 2020, and having personal avatars and other technologies that actually allow us to conduct most of our healthcare remotely, I think there are opportunities for us. Okay,
we are actually running out of time. This was a great discussion. A lot of interesting concepts. Certainly, the dialogue needs to continue, and it is our mission with Great Challenges and with TEDMED to keep the dialogue moving forward. While this ends our session, please contact us at tedmed.com to keep the dialogue moving forward as we address some of these issues and begin to move the conversation into the digital space. I'd like to thank our panel today for their kind and generous participation. And finally, I'd like to thank the Robert Wood Johnson Foundation for sponsoring the TEDMED Great Challenges program. And I'll leave you all with this thought, as I have in the past: great challenges demand great thinking. Thank you again. Bye-bye.